We do need to move on, and there are two more important topics, and that is the choice of first-line therapy. As you know, currently we have approved for frontline patients with CML and chronic phase 3 drugs, imatinib, approved in 2002 for the newly diagnosed patient. We have nilotinib approved in June of 2010, and we have dasatinib in October, November 2010, shortly after that. 3 drugs, we have to make a choice. My first questions are going to go first to Ruben and then to Raphael. Ruben, are there clinical scoring systems that allow you, that you use for choosing between these? And then Raphael, I'm going to ask you, is there any genetic information that we could get at baseline that can help us decide which of these drugs to use? Ruben?
Well, I do think the so-called risk scores are helpful, and I think that makes, I don't think that I use a score to decide on frontline therapy, but I view it as as certainly an additional piece of evidence. I mean, I think as we look at the long-term outcomes from the second-gen upfront studies, clearly there were positive studies compared to imatinib in terms of outcomes. I know as an individual in my mid-40s that if I had CML, I probably would want the very best agent that I could have. Now, it's clearly there's a lot of intriguing data that continues to be presented. Are there other individuals for economic reasons that we could start with imatinib, and if there's anything other than an optimal response at 3 months, then switch to a second-gen TKI? I mean, I think there are nuances, but I think that one, if there's higher risk, I think then the data becomes even stronger for upfront use of second-gen. I'd say that the main drivers of not using second-gen TKI upfront are really economic, and I think it's a fair discussion based on limitations and things of that nature, whether it's more of a societal discussion versus the individual patient in the room with me. The individual patient in the room with me, I typically advise a second-gen TKI as frontline.
But this is going to be a huge issue when imatinib goes generic.
Right. So I think the issue for us is, as a physician counseling a patient, how do we choose? And we're going to get to that. I mean, should it be cost driving our discussion and cost to society, or should it be putting yourself in the position of that patient sitting in front of you? What would you want? And I know we're all torn, between those two great responsibilities we have to society, but I always come back to our primary responsibility is the patient before us. Raphael, how does genetics help us? Does it?
Well, we know that BCR-ABL is not the only genetic abnormality that patients with CML have. It's obviously the driver and the defining lesion in the disease, but there are other mutations that can be found. Yet the question is, how often do they occur and what do they tell us? And the reality is that even if we do deep sequencing and we find some of these mutations, I don't know that they tell us anything that we haven't already learned from the clinical factors that Ruben mentioned, like looking at the SOCO score and so on. The one exception to that could in theory be if you could identify resistant mutations in BCR-ABL at the time of diagnosis, but these are extraordinarily rare and in fact don't always predict resistance up front. So I save that type of analysis for when patients are actually showing resistance to treatment. That's the right time to look for these resistance mutations, and really no other genes have been informative.
So to be simple means we only check for mutations at the time of failure, not responding very well. Do not check for mutation in chronic phase up front. It doesn't help. Okay. Now, I want to mention the financial question about, like, we know in 2015, Mark, you mentioned that imatinib will become generic, what to choose. We'll love to have treatment a la carte. We'll love to pick patient A, give them treatment A, patient B, get treatment B. But now the question is, and I face this question every day with my peers, I want to start with imatinib therapy. I want to get to 3 months, 6 months, assess my patient. If he's responding so well, then keep him on imatinib. If not, then I will go for second-gen TKI. Or the question could be the opposite way, like we do in AML. Let's go for induction therapy. Let's go for the best drug we have up front, nilotinib or dasatinib second-gen TKI, reduce the tumor burden, and then move to something maintenance, maybe with imatinib back or lower dose, and that we can make some saving at a societal level. I want to start with, I want to debate both of them, and obviously I want to have your opinion. If you go with the first one, I want to go for imatinib and go up if I don't respond very well. I want to go to infections. We know if we don't treat the infection very well, it's hard, it will create resistance and we'll not be able to save it later on. So the damage is already done. There is a study that is presented by Jorge Cortez at the ASH meeting, at this meeting, where patients on imatinib therapy who did not hit an optimal response at 6 months and a year 3 months, 6 months, and a year. And they were randomized by dose escalation to imatinib versus switching to nilotinib. And at 6 months after the switch, the endpoint is how many will achieve a CCYR. On intent to treat, there was no difference between the two arms. That means eventually the damage was done. Or it means that you can save these patients even later on. Or if you look into details, there was some patients who did cross from one arm to another. And if you remove the crossover patients, then the primary endpoint was met. Means there was an improvement of the rate of responses in favor of nilotinib. These kind of trials need to be done in a prospective way. Another way as well, go for nilotinib upfront or dasatinib and reduce later on to other trials. So it's still unanswered. And
So we're going to get into the